I'm Richard Walker, Executive Director of the Benjamin Rush Institute. We hope you enjoy today's edition of the Benjamin Rush Institute's Virtual Events series. This series would not be possible without the support of foundations that endorse the mission of the Benjamin Rush Institute, our student chapter members, and individuals like you. Through your support, we are able to continue informing and educating today's medical students about the benefits of patient-centered, doctor-focused methods for the practice of medicine, just like those discussed in this series. I encourage you to visit our website to learn more about the Benjamin Rush Institute and the medical students we serve. While you're there, please consider a donation to support our educational programs and events just like this one. You can donate by card, check, or by mail. Thanks for your support, and thanks for watching the Benjamin Rush Institute's Virtual Events series.
Thank you for joining us this evening. My name is Rebecca Kiesling, and I am the Director of Programs at the Benjamin Rush Institute. If you are not familiar with Benjamin Rush Institute, we are a national nonprofit whose mission is to educate medical students on free market, free enterprise solutions that they are just not getting in medical school. We talk a lot about overregulation caused by the over-involvement of big government and big pharma. Well, what about big insurance over-involvement? We're going to talk about that a little bit more, or a lot more, tonight. In previous episodes or versions of our virtual event series, we've talked a lot about transparency in terms of pricing of services before those services happen, and the importance of transparency to the doctor-patient relationship. If you are interested in seeing which hospitals are not following the price transparency rule that went into effect January 1st, I really encourage you to follow Free to Care, which is a coalition of organizations which BRI belongs to that believes in securing the doctor-patient relationship. But transparency goes beyond that bill that you get, especially when we're talking about insurance. Patients and employers deserve to know the real prices and have a trusted competitive marketplace for healthcare. There is a way to look at insurance through the lens of employer-built health plans, replacing insurer-built health plans. But why is this important? Insurer-built health plans were not geared to reducing costs. The costs just keep going up. There's no transparency, as we all know, and they're really off the shelf. They're one size fits all. Here you go. You might have heard of Health Rosetta. Health Rosetta is a blueprint of best practices for intelligently purchasing your health benefits. Their accredited advisor program, of which our guest today is one, are advisors who have illustrated exceptional transparency, innovation, and execution in the areas of risk management, employee benefits, and high performance plan design. Our guest helps design employer-built plans that save costs for everyone by cutting out the middleman. Showing employers how to better buy benefits empowers physicians to provide better care for patients without needless payment complexity. Carl Schuessler is the founder and managing principal of Mitigate Partners, a risk management, cost containment, and employee benefits consulting firm, which is a partnership of 29 employee benefit consulting and brokerage firms. Carl has more than 30 years of experience in benefits consulting and financial services. He pioneered a fiduciary approach to benefits, and which in his Fair Cost Health Plan, which is an innovative plan design that provides best-in-class benefits at substantially lower cost while improving clinical and financial outcomes for health plans and their members, that whole doctor-patient relationship. Carl is a highly accomplished speaker, and if you know that he might be pulling out the pink pants that we have seen at FMMA, at the DPC conference. The Free to Care conference was a little bit different because Carl did his talk from a tree stand. His passion is engaging in the pursuit of employer-built healthcare to replace the archaic insurer-built healthcare system because it's not meeting the needs of employers and their employees. I'm really excited to talk to Carl tonight and listen to what he has to say. You guys are going to be engaged. You're going to learn a lot. But it's really critical that we all understand insurance models as well. Not only the big, but also how it can be different. We are streaming here on Zoom. We're on our Facebook page. We have a great group of people here today, including 3 of our medical schools who are streaming this through their services as well. So I am going to turn this over to Carl, and I will be back later on. So please ask your questions. You can type them in any of the chat boxes, and we'll get to them at the end. So here is Carl Schuessler.
Thanks for the opportunity to be here with you guys tonight. Y'all better buckle up. I'm fired up. I'm tired, but I'm fired up. So I hope that I can share some good pieces of information with y'all. It's a group of people near and dear to my heart. I grew up the son of a physician. My father was a private practice OBGYN for 40 years in Macon, Georgia. I know y'all thought I was from New York City, but I'm not. Sorry to disappoint anybody. But I grew up in the deep South, and he practiced there for a long time, delivered a lot of babies. So I watched the world change for him as he went through, especially when electronic medical records came. That was more at the tail end of his career, but just all the things and what he dealt with and how things used to be. Somebody's saying, hey, Eric, how you doing? But anyhow, it was hard to watch when managed care came and kind of started to take over. And my dad was right there with a front seat. I had a front row seat as well, watching him. And folks, the world works a lot better when the doctors are in control. I think anybody would understand that. If you look at ACOs, which I don't know if anyone on here is a big fan of or not, but the ACOs, the physician-owned ACOs, physician-run ACOs, work a lot better than the hospital-owned ACOs. Certainly better than the insurance company-owned ACOs. So anyway, I really appreciate the opportunity. And I just wanted y'all to know, I guess if I get to be in the club, since my father was a physician, I do have a lot of admiration and respect. And I do believe that you guys are what makes this healthcare system go around and are the most important ingredient, the most important person in this healthcare maze, if you will. So I'll start sharing my screen. And
Carl, real quick, there's a question from a supporter saying, what is an ACO?
Oh, okay. Accountable Care Organization. They're set up where they go at risk. The doctors in there will go at risk for fees, depending on how they perform with certain metrics with Medicare, et cetera. I've spoken at a few of these things, but I'm not the expert on ACOs, but that's what they are. They've been, it's questionable if they really work or help. So I'm going to go fast and furious tonight. So this is really about how to regain control from the middles to be a physician. The middles, we're going to talk about in the insurance companies, the PBMs, pharmacy benefit managers, or program billing millions, as we like to say. This is about you guys taking control back, putting the patients first without the insurance company hassles that you deal with all the time. And we're going to show you how we're doing that. So we're going to show you a couple of examples. I think the biggest challenge doctors have, especially you guys coming out of medical school, is you've got to understand the world we live in, because with the way the world is headed, you guys need to be direct contracting with employers. You need to be doing a lot of innovative things, because at the end of the day, if this thing ever gets to single payer or any of that, the insurance companies don't care about the doctors. I think they've proven that over and over. And if you think insurance companies are in the healthcare business, then we probably ought to end this webinar right now, because they're not in the healthcare business. They're in the money-making business. All right, so let's look at this video. Real quick background. Please watch this closely. This is one of our clients. It's a rural hospital in Arcadia, Florida, DeSoto County, Florida, about 35,000 people that live down there. Rural hospitals all over America are threatening to close. It's a major problem in our country, over 450 threatening to close. And when they do, that town they're in just goes kaput, because jobs, education, healthcare is why people move places. The patient rights advocate, I can't say enough nice things about them. If y'all don't know who they are, check them out, patientrightsadvocate.org. They heard about some of the things we were doing down in Florida, and he reached out to a good friend of mine, Marnie Jameson Carey, to say, hey, she's testifying up there on the Hill right now, I believe, and with about the Association of Independent Doctors. But because of her, we found out, they said, hey, do you have any case studies in Florida that we could show? And that's what they did. And they contacted us. Our clients agreed to be on camera. And here's the end result. So I'll shut up and let you hear it. But I wanted you to understand, these are not advertorials. They're not paid for. These people came to us and wanted to film our clients. So we're honored. And Patient Rights Advocate has got a front row seat at the White House on every bit of legislation. All the transparency you saw through what Rebecca was referencing, a lot of that was Patient Rights Advocate pushing that through the last administration. That's what they do. They're your friend, and they're trying to bring some rationality to this healthcare system and help fix it. And transparency is certainly a big key. So I want to thank Patient Rights Advocate again for this. And here's the video.
We are self-funded here at this facility and have been for 30 years. Our premiums kept going up and up and up. We're a small 49-bed hospital, and we realized that we've got to do something.
When we met Desoto Memorial, their health plan spend was about $2.2 million. We just wrapped up the first year, and the spend was around $990,000. So they saved $1.2 million, or 54%.
It's remarkable how much you can discount the price of something if you know you're going to get paid at the time of service.
What do we eliminate? The middle. We're going direct. That's how you save. It's direct to employer contracting. We negotiated a cash knee replacement price. That hospital was $70,000. We got it for $25,000.
Direct primary care, where you just pay $65 a month, and that covers all of your primary care. And sort of the bundled cash payments are two prongs of things that we can do to actually reduce the cost of health care. We also have a program that's called the Medical Advocacy Program.
They walk you through the process.
It was kind of blowing my mind when they turned around and said, well, we'll do everything for you.
Getting them to the right doctor for the right quality, lastly the right price, and at the right time. That's what this is about.
The less we have to spend on plan, the more we're able to put back into salaries, back into maybe additional benefits or increasing benefits.
This medical expense per employee per year. We met them, it was almost $14,000 per employee per year. It's now right around $6,000.
Biopsy comes back, positive for cancer on the left side, and a week later, I was headed into surgery. As of today, all is well. I have gone through the process, an estimated cost of $42,000. What did I pay? Absolutely nothing.
And there was a lot of cost savings. So I actually got the bill 3 days ago, $31.76. An MRI is thousands of dollars. If something were to happen to me, or God forbid, one of my family members, it's covered.
The opportunity to take this model that DeSoto has can be replicated across the country in all these rural areas. Absolutely.
Not having to sit around that board table this year and say, okay, how much of the increase is going to go to the employees out of their pockets? I was giddy. I was excited that we did not have to do that this year.
And we deserve that. I know I do.
Well, that fires me up every time I see that. That, guys, is, if you caught a couple of things, eliminate the middles. You're going to hear that over and over tonight, so get used to it. My dad always came and turn the light off, son, turn the light off. Told me 9,000 times, and I do it to my kids now. So I'm going to beat that one to death with you guys, because that's what you got to do to take back control. You got to get these insurance companies out of in the way of you giving care. Again, they don't know anything about health care. So with that being said, that's a great story, and that video has been shared a lot of different places all around the country. All right, no time to hear what we have to say today. As I always like to say, we've got a battle to fight. I ain't got time to see some crazy salesmen. So we're not selling anything today. When we don't sell insurance, we build health plans. So let's move forward. Hope that made somebody laugh. All right, this is a slide we've used for a long time. I think I got it from Dr. Lee Gross, who was the direct primary care doctor at DeSoto Hospital that brought us to DeSoto. But this is the problem, guys. I mean, how can a doctor take care of a patient when they have to look through the ears of the third party, the middleman? And that right there, I think, just sums it up with one picture. And we can end right here. But that's the problem we've got to work on. And that's what this talk is about. So what's in this for you? It's to learn strategies, to eliminate the middles, direct contract, creating your own doctor specialty network potentially that you control and you run. And also allow you to practice medicine your way and on your terms and be paid hassle-free. And we're going to get into a lot of that. And then you can go back to putting the patients first without having to justify yourself to insurance companies. In the fee-for-service environment that a lot of physicians still play in, it's a fee-for-service. They've got to see 4,000 patients a day to pay the overhead in their office. The average visit right now is like 7 minutes. And that can be resolved with things like direct primary care. So any of you medical students up there that are going to go into residency or do internships at some point in the future, really consider looking at direct primary care, DPC. It is getting care back to the way it used to be. What's funny is we've come full circle now. We've gone back to the way it used to be. But we got to get out of the fee-for-service environment. It promotes usage and a lot of extra tests and things that aren't required. And also, at the end of the day, you lower your stress level. And I think you become more productive, increase your revenue, and your practice can put more money back in the community and allow employees to have better benefits. Key themes today: build employer-built healthcare versus insurer-built. Rebecca hit on that. That's another theme you're going to always see. If you follow us on LinkedIn or follow us anywhere, we're always talking about that. That's the key. And then you've got to actively manage your plan. Well, it's hard to do it when you're in a term we affectionately refer to called the BUCAs, Blue Cross, United, Cigna, and Humana. When they're at the realm and they're controlling the strings, it's all passively managed. Again, it goes the inverse opposite of their stock price. So they don't want costs to go down. That's the last person that wants costs to go down because of the Affordable Care Act and what it did to the insurance companies. It actually made them a ton of money. We'll talk about that as we go forward. So you have to actively manage your plan. And well, let's get back to relocalizing care. We call it repersonalization of care, like the Marcus Welby MD days. Any of you guys in med school out there, y'all don't know who that is, go Google it. It's terrible. I talked to so many people don't know who Marcus Welby is, which says and I know I don't look old. I look young. I mean, I'm only 53. I look young, don't I? But I mean, we got to get back to that day. That's when healthcare worked. Neighbors taking care of neighbors, neighborhood healthcare. And then focus on building community-owned healthcare versus this archaic insurer-owned. It should be Alexandria, Virginia-owned healthcare or Arcadia-owned healthcare, not BUCA-owned healthcare. And then we got to get everybody engaged. It wasn't long ago that the pharmacist, the doctor, the hospital, and the patient, they all could work together and talk together. And today, the community pharmacist is about gone. Unfortunately, I'm a huge community pharmacist proponent, and we've even put a program with Mitigate Partners with Pharmacists United for Truth and Transparency, PUT. It's called PUT. But I mean, these community pharmacists are critical, and they give great care, and they can do it all together. We're going to talk about the local care team in a minute. And again, at the end of the day, these employers that have these benefits, or like your medical school, I'm sure the medical school, if you have a program there, is probably one of the BUCAs. I'd be shocked if it wasn't. Shame on that medical school. But anyway, you can break free of the status quo and have 10,000 benefits for half the cost. You saw what DeSoto had. No deductible. No deductible when they say 1.2 million and 54% on 157 employees. Crazy. And there is a way for you to have health insurance your way and on your terms. And that's what we're going to talk about. Quote of the day: healthcare is not broken, it was made this way. I don't know who said that. I say it, and I'm sure many other people have. But make no mistake, these people are geniuses. And unfortunately, I didn't buy any stock in all these cartel insurance companies. Otherwise, I might not be sitting here with y'all today. But I mean, it is not broken. It was made this way on purpose. And again, what we got tired of is this. You can't solve these problems with the same thinking we used when we created them. We got to do something different. So let's set the record straight. And this is I get real fired up on this topic. Payer. And again, you med students, you might know what a payer is, but when you're in these positions at a hospital or other organizations, they talk about the payers. They refer to the insurance company as the payers. They're the payers. Well, are they the payers? Because they don't pay claims. Insurance companies don't pay any claims. So if your card's got a Buca logo on it, they're not paying claims. Your physician's practice and your employees pay claims. No insurance company pays claims. They process them and call them the processors. We met with a large hospital system in Florida back a year and a half ago, and we sat there for 3 hours with the chief revenue officer. And by the time we were done, I had them using the term processors, because the payers is what they always talk about. The payers are the businesses and their employees. That's the only payer out there. So don't forget that. And then get reimbursement out of your vocabulary. How's my dad getting reimbursed for delivering Eric Dreyfus's baby? What? He's getting paid for his service. He's getting a payment. Now, for Becca, and takes me out to dinner and I pay her back, that's a reimbursement. That's got to change. It's payments for work you did. And lastly, provider. I hate that term. It is so vague. It refers to many things. And I think it's physician and facilities. And then I'll get off my soapbox here in a minute. Guys, this is a ID card, a medical insurance ID card that you might have. If you've got insurance, you have a card like this. Why in the world are we giving the Bucas free advertising space? That's free real estate. I tell you what, I'd love you to put my picture of Mitigate Partners or Fair Cost Health Plan up there. I'd love the free advertising. Why are we doing this? This is your company's plan. It should be their logo up there, not an insurance company. So get that fixed. Don't hide behind these Buca logos, folks. All right, and our mission is aligned with y'all's. We're trying to improve patient experience, improve the patient outcomes, reduce cost, and lastly, improve care team experience. And that's called the quadruple aim. It used to be the triple aim, and that care team. And if you've been, fortunately, knock on wood, we haven't had to be in any hospitals in a long time, but that care team experience a lot of times is not where it should be. And that's what we've seen. And you can tell with it when you see it. All right. Now I'm going to wrap this piece up on neighborhood health care. And I want to talk about that for a minute because this is different. Here's the definition. I'll let y'all read it. You see the same thing again, coming up again. We've got to let the doctors take care of patients. And we have to get rid of these counterproductive barriers that keep them from doing it. All right. So here are the challenges that you guys are going to face as y'all get out of med school. Any other doctors that are listening out there? I mean, y'all know this. You've got pre-cert you got to go through. How many millions of dollars a year does your practice spend going through the pre-cert process? In our plans, we can customize pre-certs for certain doctors and everyone that meets good quality metrics. We don't always have to do pre-cert. We've created our plans limiting some pre-certs at times for certain procedures and certain physicians. That makes your job a lot easier, and that's a real problem. Prior authorization is very similar to pre-cert. You have to go through that, get the approval. And then these peer-to-peer reviews, these are my favorite. How much time do you spend on that? Those are real problems in the system right now. And some of those things do have to be there. I mean, we have some of these in our plans, but like I said, you can customize the plan when you get away from a Buca. And that's what we do. They're always throwing roadblocks at you and, but you got to rely on them because they're giving you your patients. I mean, those patients that buy insurance with Blue or United Healthcare, they're coming to you because you're in their network. And so you gotta be careful. The broker's a roadblock. If you call me a broker, I'm going to jump through this camera and come up there and whip some tail. I'm not a broker. I'm a benefits advisor. But a lot of the people that we compete with out there that are trying to help employers build their health plans are brokers. And they get paid when they bring an insurance company together with an employer. And that's and so the broker is a roadblock because they don't want complication. You can't get in the deer stand as quick. You can't get on the golf course as quick if you got to work a little bit harder actively managing a plan like we do. And all brokers aren't created equal as all doctors aren't. And y'all know that whole old adage where they say that what's the difference between a doctor that somebody that graduated medical school with a C and someone that graduates with an A? They're both doctors. Y'all have all heard that before. So all doctors aren't created equal. Some doctors are tremendous surgeons. Some aren't. That's just how it is. So all brokers aren't either. And then you got to find benefit advisors who aren't 1099 employees of the BUCAs. Let me explain that. If you look at their tax returns or get all their 1099s, how many of them are coming from the BUCAs of the world? Blue, United, Signet, and Humana. Many of them are. We don't have a lot coming from them. Our business, we don't. But they're really essentially 1099 employees because the more business they do with that insurance company, they get bonuses for the more business they do. So you got to find people who are not married to the brokers. Married to the BUCAs. And then you need to find benefit advisors, Rebecca referenced this earlier, that are population health managers. That's what we're doing. That's what you're helping us do, manage a population, a risk of an employer. And Health Rosetta does a great job. We're blessed to have been a part of and one of the original members of Health Rosetta, the first 30. So it's a wonderful organization, and they're doing everything to move these initiatives forward. And again, you got to find a benefit advisor that understands doctors and that knows how to integrate a doctor into a high performance plan for optimum performance. It is an art. It's not easy. And again, it requires a little bit of skill there to do that. And the BUCAs are extracting millions from your communities. That's a real problem. So let's look at that. This is a picture of healthcare in America. If you look behind you out the conference room, look at all the names on all the buildings, on the stadiums. And look who's at the table. So when we're out working or an employer sitting on this other side of the table, who's sitting on their side trying to help them? Because the more there's all these misaligned incentives, the more the premiums go up, the more everybody makes, except the employer. They're going broke. And then this is your updated 2020 Fortune 500. It's probably one of my favorite slides. I want to show you this. These are all healthcare companies. These are all middle people that don't make anything, produce anything whatsoever. They're a middle person. So here's what you've got. I want to show you this because it's amazing. Those are Optum is the PBM for United Healthcare. Express Scripts was an independent company, and then Cigna and Express Scripts merged. Cigna was 65th last year. They moved to 13 when Express Scripts and they merged. Unbelievable. 52 spots. And then if you look at CVS, now Aetna became CVS. So I put Aetna there because it used to be Aetna. And then if you look at the companies that make the drug, Pfizer and Merck, look where they rank in the Fortune 500 at the bottom. And then Anthem, huge, part of the Blues, and Humana, look where they are. All of these middle people are eroding our country. We're making the population functionally uninsured where they can't afford insurance anymore. And this is also a picture of how the drugs are distributed. I'm not real smart, but this looks pretty complicated to me. You got the employer and the member, and that's all the channels this stuff has to go through. And if you notice, every one of those companies I just talked about were on the Fortune 500. All the middle people right there. Every one of them. So real problem. I just want you guys to know that. Now, this is one of our clients, and this is a 10 years of salaries and insurance cost. In 2010, their salary was $46,000, and that was their family health cost, which was 14% of their pay, $325 a pay period. 10 years later, this is what it is. So their pay has gone up 3.85% over 10 years, and the insurance has gone up 39%. No raises to speak of because the insurance costs are eroding the chances for them to get salary increases. So that's why I wanted you to see. Now, all along, while that was going on, look at, for example, at Cigna's stock price. Look where it is. It went up 573% over those 10 years. I said, I wished we had bought some. So that's a real problem. Now, I got some humor for you, so hopefully y'all will laugh. I was telling you guys, they jumped from 65 to 13th last June. A buddy of mine made that video, and I think it speaks volumes. And I hope that they'll try to do something to help erode the cost that we're doing. One other quick thing, when Rebecca talked about transparency, patient rights advocate is all about transparency, as we discussed earlier. What if we bought groceries the way we buy healthcare? Think about that for a minute. What if we bought groceries the way we buy healthcare?
There are no prices on anything here.
Oh, believe me, some of it's pretty spendy. Whoa, that's really gone up.
Okay, stop. I don't need both, just one or the other. It depends on the price.
Oh, that's called shopping. We don't do that here. Thank you for coming in. Your bill? Your version will be mailed to you in 30 days. Good luck trying to make some sense of it.
Now, I guarantee you there's a few of you out there laughing at that. And if anybody knows if I'm speaking in public, I will jump down somebody's throat on that. There's nothing funny about that at all. Think about it. Do you go to Best Buy and buy a flat screen TV and take it home and not know what the cost of it is for 30 days?
Carl, you lost your, Carl, you just up there. You're back.
Thank you. I saw it. Thank you, Rebecca. So do you do that? Of course not. Why in the world in America are we buying healthcare not knowing what the price is for 30 days? It's crazy. Remember, healthcare ain't broken. It was made this way. It's truly unbelievable. I mean, would you buy a car and then find out what the bill is 30 days later? Of course you wouldn't. You'd know what the cost before you bought it. Got to fix it, folks. Pathetic. All right. So what we've got today is a lot of what we call passive health plans. So let me explain this. This is what we call a BUCA insurer-built. Rebecca talked about earlier. I covered a little bit. This is that insurer-built plan. It's easy. The insurance company provides all of these little tools, all of these items, hospitals, outpatient. It's paid for. You're paying for it, but the insurance company's providing it. And it's really, really easy. It's the easy button, and it's great for us because, like I said, we can get on the golf course and get in the deer stand a lot quicker on these plans. I can promise you that. And the only person getting rich is the insurance company. Unfortunately, it's your expense. So we were frustrated, and I love Buckminster Fuller. He's a great, famous inventor. And we just said, we got to build something else that makes existing model obsolete. So we went and built the Fair Cost Health Plan about, I think when it was maiden voyage, July 1st of 16 is when we started it. And so we're going to talk about it in a minute. Now, insurer built versus employer built. And I know that, Rebecca, I've been told, and I think everybody knows me, I'm not real politically correct. I understand there's some problems with Mr. Potato Head lately in the news. I haven't tuned in the news in a number of months. So I apologize if this offends anybody. But that's a Mr. Potato Head. And that's a lot of employers feel their health plan looks like that. Hey, my Mr. Potato looks pretty good. It's insurer built. It's not really delivering results, but it is easy, Carl. Well, I tell you what, when we see your plan, this is what we see. And we think it's time to hit the panic button. And so what we did is, because we couldn't find any solutions, we got tired of delivering bad news year after year, these employers and premiums going up. What could we do? So we deconstructed and unbundled and rebuilt the system into more of an actively managed platform. Just think about Mr. Potato Head, pulled all the parts of all the pieces out. And then you come up with a human patient centric plan. This employer bill, Captain America, Mr. Potato Head, a good looking Mr. Potato Head. But again, maybe that's not good enough. I know Rebecca, she told me she didn't like Captain America. So Rebecca, I've got you covered here. Maybe Rebecca wants Wonder Woman, Mr. Potato Head, or Homer Simpson, Mr. Potato Head. But the bottom line, she should be able to pick it. Every employer in America should, because should be employer built. It should be your plan. You should design it the way you want to design it. And this is our example. We always relate building a health plan like a house. And it starts right there for any of you guys listening that are direct primary care doctors. DPC is the foundation of it. That house has to be built on bedrock, and that is DPC. We're tremendous proponents of it. Dr. Gross, Dr. Crouch, I can go on, Dr. Gold, Dr. Purcell, I can go on and on. Tons of people out there that have done so many great things for healthcare, and this is one of them. And then, as we told you, we deconstructed it, we rebuilt it brick by brick. These are different bricks we vetted over the last 7 years that go into this plan. And all these bricks are present. Now, I will tell you that in the insurer-built plans, these bricks aren't present. You might have a few of them, but I promise you they're not the best bricks. We tried to find the best all over the world. It took us all over the place to try to build this, where you get a custom employer-built, actively managed health plan. That's what we're trying to do. That's how you do it. And guys, y'all come in here because you can be inserted in. But right now in these insurer-built plans, you can't get inserted in. Hey, unless you're in their network. And then every doctor's in the network. The networks, they cover everybody. You want steerage and you want to have people come to you and have it set up that way. We're going to talk about that in a minute. All right. So it's employer built, and everybody, nobody ever asked, but I'm going to tell you, I don't, fair cost. We wanted to call it fair price, but that name was taken. So fair cost, everybody wants to be treated fairly and pay a fair cost for services. So it sounded like a good name. If you got any ideas, please put it in the chat room, and I'm sure Rebecca will let me know. All right. So this is what we're after. And this is what I want y'all to see. It's a little complicated, but it's really, really important. That's the person you want to get to if you're a doctor. You want to talk with a patient, the person that's on the insurance plan, the person that's got the health insurance at that employer. Then you've got a pharmacist, you got primary care, direct primary care doctors, and specialists. And we call that the local care team. I call it the love triangle. Maybe a little perverse, but we call it the local care team, the love triangle. Then you got the employer, okay? They're up there. You want to get the patient in the center? This is the problem I'm going to show you. Now, we're good because we're population health managers and we're benefits advisors. We're not a broker, so we're a little different, but that's where that broker will reside in most health plans. And then you got your third-party administrator that pays the claims. Remember, they process the claims of the processors. Then you got your claim data analytics. That's really helpful for us so we can look to see what's going on with the member population. And then I think Dr. Gross would tell you with Desoto Memorial, we've been able to team up together and do a lot of things where we can notify him of things. He tells us of stuff, and we can provide integrated, coordinated care, IC squared, that we can help with. Then you got your PBM, that's your pharmacy benefit manager. That's where the drugs come from, the RX scripts, program billing millions also. And then you got an RX consultant we always use because they've forgotten more than we'll ever know about PBMs. That is the biggest shell game in the history of the world. And I'm not going to profess to try to know it. So we've got an expert that works with us in our plans. And then you've got utilization management, disease management, case management. The UM is that pre-cert, prior auth that we talked about. The disease management, they help work with obviously comorbidity factors, and the case managers are actually working with the members. And I will tell you, case management is pretty much non-existent in the insurer-built healthcare. I'll give you one case in point because this is going to be important. I'll cover that in a minute, actually. All right, so that broker or that benefits advisor is the most critical person to allow y'all to get to the patient. But the broker today is a roadblock for you because this is work building these plans, and it's not easy. So this is what we want to really sum it down into a few parts for you guys. Keep it simple. This is how the health plan should work. You want to talk to the employer. You want to get to the medical plan participant. What we often find, and we're going to talk about some of the pitfalls that the DPC docs have had trying to acquire clients. If you go to the employer and you know them, they're pretty excited about what you're talking about. Then they go to their broker, and the broker goes, "Oh, you don't want to do that," and you're out, and it's over. It's over, and that happened over and over. I spoke in front of the DPC Nuts and Bolts conference down in 2019, Dr. Gross's conference. We shared the Desoto Memorial story, and I can tell you that that's the common theme you heard. I went, but then their broker said they didn't like the idea. You got to find a benefits advisor that's a population health manager. That way you can get to that patient. And then this is critical that we team up together in these areas and that we get good claims data so we can find out what's going on with the population and then help address them with some of the cost containment solutions y'all saw in the house. Now, here's what's critical. I know that house looked complicated to you, but this is all that employee that works at that employer sees. They just need to know where the front door is. One call, that's all. And that's it. They don't even know what's behind the sheetrock, the plumbing and electrical. It's already covered. We covered that earlier. They don't need to know. But I will tell you, no house is complete without a dog. Go Dogs. Had to get a word in there for my dogs. All right. Now, here's a fair cost health plan. This is what we've done for a hotel. We've done this for, a lot of clients, but I want to show you, look at those high deductibles they have. I mean, can you believe that 0 deductible? I don't know how they're going to afford that. Generic drug copays. I'm going to go kind of fast. Got to pick the pace up here a little bit. I'm running way behind. These are the things. On the right is what most health plans, and that's what they charge their employees for dental and vision. Critical benchmarks, that's their medical expense per employee per year. The national average is $12,125. $47 for drugs per member per month, 120 actually. It's 125 now. I need to update that. But that's the difference of having a plan. And look at how rich that plan is, and then look at those costs. If you design the plan right, eliminate the middles, it can happen. I'm going to give you a little bit more on Desoto. That's Vince Sika, the CEO, Lois Hilton, HR, also Dan Hogan, CFO, and many others there were very instrumental. Dr. Lee Gross, like I said, was instrumental behind all of this. But this, I want to give you, we're not going to share their perspective. You can go on our YouTube channel and hear about it. But I wanted to show you who the players were in this, because they're the ones that get the credit. They're the courageous employer that went out and did something different. And if you ask them, they wish they had done it years before, which is good, because it's not easy, but that's what they say. So solutions, we eliminated the middles, moved from a BUCA TPA model to an independent TPA, active management, eliminating passive management. We relocalized care, neighborhood health care. We also utilized a cost and quality transparency tool where we were also able to work out direct cash deals with different hospitals and also certain specialists. And again, they got 10 times the benefits. They weaponized their plan design in the hospital, still in process of coming their own PBM. They implemented direct primary care. Now that, what might sound strange to y'all, they're a hospital. They own doctors. Why'd they get direct primary care? They're that big of believers in it. And what it's done for them, the 1.2 million, 54%, Dr. Gross, Dr. Crouch, and the office manager, Ann Horner, have everything to do with it. We did some good things too, but that was the most critical part, the foundation of the house. It's you guys that helped make that happen. And we were able to work with you and put you in the plans. And then we implemented our fair cost claim analytics, and we talked about integrated coordinated care as well. So here's what it boils down to. This is kind of the deal. They're a 4-star CMS hospital, only like 19 in the state of Florida. They're a 4-star, tremendous hospital. Here are the challenges they were faced with. They're fourth poorest county in the state of Florida, 25,406 per capita income. They lost obstetrics in February of 18. I was telling my dad that story. I mean, that's just painful. They have to drive an hour to have a child now. And their foreign medical spend, that's the amount of money claims that their health plan was having that was going away from their hospital, okay, for the last 5 years. And then that was their spend when we met them. The results, they saved $150,000 in their stop-loss premiums, which was huge. And they weaponized their plan design, implemented DPC, we just covered, and they hired their first full-time surgeon in county history with all that savings. That's a game changer, folks. That's a big deal. And their foreign medical spend went from 79 to 62%. All of a sudden, Carl, who worked at the hospital for 20 years, now is going into the hospital that he's worked at, because now he's not as worried about somebody seeing him naked. He's going to go in there because there's no cost to him to go in there. And it's a great hospital. So that's a huge change. It's now at 40% now, which is great. And so they had a rate decrease. How many of you ever had your rates go down on your insurance? They had a rate decrease. And again, that's their savings. And then 3 months with the BUCA ASO, for 3 months, they were with the BUCA, and 7 months on fair cost. You can see almost the same identical cost for 2.5 more months as it was for 3 months with the BUCA, the insurance company built healthcare. Folks, that's the key. What we're doing here is not rocket science. We're eliminating the middles, and we're building a better plan to get better outcomes for the members and better and financial outcomes for everybody. So that's that. You already saw this. I'm going to move fast. You saw how much they saved. That's the number when we met them, and the green's on the right. All right. Real quick, I want to play Hannah's story. I want you to hear this, because the other problem we got in America is most plans have made Americans functionally uninsured. because it costs so much, the deductibles are so high, the members are scared to use their health plan. And most people don't have $500 in their checking account. I want you to hear what Hannah says. These are benefits for us, not done to us. That's huge. And then also hear what her thoughts were before she never used her plan because of the barriers to care. We removed all barriers, and here's Hannah's story.
Well, the benefits that we have here at the hospital are more so focused on the employees. The latter part of August, I had a concern regarding my neck, and I went in to see my primary care, listened to my concerns, and he recommended certain protocols. It was my choice of what I wanted to do. You would think with the specialist, the appointments are so far out. Within maybe 3 weeks from seeing my primary care, having my test done, getting my results, finding out that I need to have a biopsy done. Biopsy comes back positive for cancer on the left side, and a week later, I was headed into surgery. As of today, all is well. I have gone through the process, an estimated cost of $42,000. What did I pay? Absolutely nothing. So before, I was paying all that money on my premium, and I never used the plan because I was reluctant because of, I have this copay, I'm gonna have this deductible. We don't have those issues. Every concern I've had since day one of this plan, I have addressed and have taken care of this year. And I've paid absolutely nothing out of pocket. And we deserve that. I know I do.
Man, how great is it to have a courageous employer that took that step to do that? I mean, that story right there almost brings tears to my eyes because she's now taking care of herself and she wasn't before. So our next process was taking it to the streets, city, and the county, and the school. We want to take this whole model to all of them, and we're in the middle of it. And then COVID hit, and y'all know what happened, the rest of the story. So we're still working on this, but there's a great opportunity to have this be the hub and the nucleus of that town and build Arcadia-built healthcare for that community. And it absolutely can happen. So here's the reason for, we say no networks or custom networks. The hospitals are turbocharging their rates. I'm at unprecedented levels. Here's an example. That blue line is the bill charges and the red line's their cost. So these are a lot of fictitious numbers made up. They're throwing darts at boards. The cost is down there. It's published to CMS, Center of Medicaid and Medicaid Services. We have access to them. We know exactly what it costs from doing a CT scan. Yet they're going to charge 30 grand for it, like one of our clients had done when they were in an insured bill plan, 4 or 5 $30,000 CT scans that we're getting for under 500. All right. And again, this is just a quick example. These are stories from the crypt, as I say, with our client, one of our clients. This is a fractured radius at the top, and it's a fractured humerus on the bottom. That was the billed charges from the hospital that came out. For a fracture, not a break, not a shatter, a fracture. And some of the BUCAs get 50% discounts, but it say it's 30% off a bill. That would have been paid if you had been with an insurance company. This is what we paid. Pretty good there, huh? And you want to talk about discounts? How about 89% discount? So anyway, that's a real story from our client, and those are just examples of what happens. I don't think a lot of the physicians out there know this goes on. You know what you're getting paid, but do you know what's happening behind the scenes? It's really scary. All right, and the stock price growth of these has been enhanced since the Affordable Care Act came out. These are not the most up to date, but that's 09, and then you can see 18. You saw the Cigna stock price. I don't need to say any more than this. So now let's get to the heart of the matter. As you guys come out of med school, or any of you that are out, how can you acquire clients? Some of this is going to be a broken record, but you got to educate yourself, become a student of the game. And knowledge is power. And all of you guys are voracious readers. You had to be to get to where you are. I took biology 101. I was pre-med like my dad. And I knew right then and there that was not for me to do. So that's a big thing. And And I want to encourage you to read the following books. I'm going to go fast. But this is The CEO's Guide to Restoring American Dream by Dave Chase. This is the co-founder of the Health Rosetta. And again, we were one of the original 30 to go through here. And this is a big deal. This book, each chapter stands alone. You should read it. It will educate you and you'll learn about our side of the fence. You've got to understand our side of the fence. These DPC docs like Dr. Gross and Dr. Purcell, and I'm going to leave many out there, Dr. Carl, they all are students of the game and they understand what goes on this side of the fence. It will equip you to win. So here are a couple of books. Dr. Marty McCary, I'm sure many of y'all know him. He's on the news all the time now with a lot of the COVID opinions. Dr. Rosenthal, Elizabeth Rosenthal, the editor of Kaiser Family Foundation, and then Catastrophic Care. Those are great books. Take pictures of the screen if you want to. I charge $100 a picture, so please send your money to me. Thank you. And then this is another book Dave Chase did, and there's several of our Mitigate partners in there. They got case studies, including yours truly in the pink. By the way, this tie is for that client. This is the pink elephant tie for the Pink Elephant restaurant, the Gasparilla Inn. It was made for them, and you notice it was in that video too. All right, and then the opioid crisis, got a big problem in our country. That's another book Dave Chase wrote. And then his most recent one is just out, Relocalizing Care. And again, the Gasparilla Inn case studies in the book, so you can get that if you need it. I can get you a free link to it. Let me know if y'all want it. Rebecca can help with that, and so forth. And there's the stuff about the hotel in the case study. And then lastly, if any of you are thinking about becoming direct primary care doctors, Dr. Purcell wrote a great book. He was, I don't know why he quoted us in the front of it, but anyway, he is a bulldog, so that might have something to do with it. And then Christy Gupta, one of our Mitigate partners also up in North Carolina, helped a lot. And we also gave a perspective because asked Dr. Purcell what he learned from these brokers. I mean, it's crazy. And they really understand the system. And these are great books, real easy book to read. Biggest roadblocks of broker, I covered it. All brokers aren't created equal, as doctors and direct primary care doctors aren't either. And you got to find benefit advisors who aren't 1099. Find benefit advisors who are population health managers like the Rosetta we talked about earlier. So here are the Mitigate partners, 29 independent firms. We don't own anybody. They're all independent. They're all over the country. And we collaborate together and work together on cases. We want to have a case worked by local management. So we want to have that people with the boots on the ground having that case. And that's what we do. And again, about 95% of them are the Rosetta advisors. And we have a different view of the world because we're not myopic in our view. We're looking at what each other. I bring something that Christy Gupton didn't know, and then Christy brings something to me. That's what we're able to do with our partners across the country. So it's been a really good thing, and it's really taken off. And then you got the Health Rosetta that Rebecca again referred to. There are over 200 Rosetta advisors all over the country. I can give you the website. You need to connect with one of these benefit advisors, and we can help you with that too. And again, you've got to find the benefit advisor to understand you and how to integrate you into a high-performance health plan. We spoke at the Ortho Forum last February of the largest group of independent orthopedic surgeons in the country, about 5,000. There weren't 5,000 there, but 500 or so. And that's what they all need to be doing. They need to be doing direct contracting with employers. They need to cut out the insurance company. It's got to be careful on how you do it. Take a benefits advisor. They can help you. And take them on meetings with you. Do not try to go alone. I promise you, you will fail more times than you will win. And you need an employer-built plan, eliminating the middles to make that happen. And then build a community marketing plan. Just quickly, I'm going to go fast because I'm way over my time. Sorry, Rebecca. Think about all the people you know in the community. Most people are pretty connected. Make a list of all the folks you know. And then work on it. Come up with their names and who they are and what their email addresses, et cetera, are. And then you do that. And then you build a list. And if you know people, get you a good benefits advisor and go with them on appointments and learn this business. I can't overemphasize those books up that we showed you. Those will really help you understand how this system is stacked against you and trying to eliminate you too. All right. speak at relevant local events all the time. I know that a lot of direct primary care doctors have done that. Other doctors do this. You need to do that. And heck, we can get you on a speaking engagement in a local community if we're working in that community. Have you come speak about your specialty and what you can do for companies working direct. And then organize an event with a benefits advisor, and then find your local business coalitions. Christy Gupton, you heard me mention her name a couple times, is famous for saying all it takes is a good advisor and a little courage. And do we think we're good at what we do? Sure. I mean, we may not know how to dress, as you can tell today. By the way, I do have these pink pants on. Can you see them? No, everybody was asking about it, so they are on. I just pulled a muscle doing that. Ouch. But the courage is a courageous employer, and our job is to make that employer courageous to take this step, which will allow us to insert you in as well. So that's critical. And then, enough of this. Everybody, all this stuff's different and it's new, and I'm an early adopter. No, you're not. Mount Everest was once unclimbable. Now there's a litter problem. There's oxygen bottles all over the place. It's a mess up there. People die every year, but a lot of people make it to the top. No more excuses. You can do this. So thanks for your time. And again, hope and luck is not a strategy. You guys have got to get out there and take control of this thing. That's how you'll win. Thank you.
That was great. I know we usually, for people who have been here before, we try to keep this in an hour. We're going to go just a smidge over because I really do want to get to some of these questions.
Sorry for going long, Rebecca.
I
never know what's going to come out.
Yes,
I never know what's going to happen.
Fully expected. I thought every time that you said in the past hour, every time that you said that your benefits advisor shouldn't be a employee or be associated with the BUCA or the large companies, I laughed because I love the fact that Andy Slavitt, who the COVID response advisor, was a United employee. The conflict of interest, in my opinion, at least. I mean, that's kind of we're talking the response to COVID right now and our government response. So
it's a cartel, Rebecca, 100%. And everybody goes, it's that pink pants cartel guy in the deer stand. Let me tell you, it's a cartel on purpose.
So a couple of questions I want to get into. Can you talk about how mental health fits into your system and into your plan?
Great question.
Not just outpatient, but inpatient too.
That's a great question. That is something we do have a tremendous solution that we have not deployed successfully enough, I will say. And obviously, I don't need to tell everybody all the problems our country's having. And all the mental anxiety that's going on out there is a real problem. And the opioid abuse is way up too. When we do have a solution, and I don't know how much detail you want me to go into, but we do have a solution with an organization with access to enough. The problem is finding the doctors that can help, and we have an organization that's been able to do that. And so glad to share that later with anybody.
Right. Okay, here's some acronyms that I don't know. So you're going to, this person though, because he's one of the many people that were commenting on number one, and you didn't talk about why, how clean shaven you are, but number two, how about the pink and how great you're looking. So,
wow. Well, thank you. We try, and the real key to dressing like this is I don't really care what anybody thinks. So that's how it works for me.
So here's the question. What about the number one cost in healthcare, MSDs? How do you address this? DPC, accuracy of DX is pretty low and still more costly than solutions like Solve Global and Proactive MSD. Now, you have to explain what that means first.
Well, I think, is that coming from my boy, Eric?
No, Tim Spooner.
Oh, oh man. See, he's lucky. It's like 8 a.m. where he lives. I mean, golly, they do their free market medicals. It's like 9 o'clock my time. So thanks for joining us, Tim. Tim, musculoskeletal is what you're saying. Obviously, musculoskeletal disorders. We've got a solution in our program, and we use the same solution that Michelin uses. And what we're able to do with our utilization management, the good part of it, when the claim comes in, are they asking for a particular ICD-10 or ICD-9 code that might be an MRI for a lower extremity? It's not an ACL blow or anything like that. Those are flagged immediately and are carved out and sent to our high performance healthcare partner that works in that area. And they go through a course of treatment, usually like $700 for about 20 visits. About 7 times out of 10, surgery is never necessary. And unfortunately, there's a lot of cutting that happens, in that particular specialty. Sometimes it doesn't need to happen. So, and a lot of unnecessary treatments are done for people. So that's how we deal with it. I hope that helps. If it didn't, you can call me later.
This is a great piece of advice, and I'm sorry if I don't know who this is from. I'm not familiar with this name. Another piece of advice: plan to rotate with, and this is just a general piece of advice to our students who are on here. Plan to rotate with a DPC office and connected specialty practices during residency. I love this. I love this. One of the things that we're trying to do on this program is not just, we have fantastic DPC doctors that we've spoken to. I'm a huge fan of DPC. FMMA, Free Market Medical Association, tweeted this out earlier today. It says, direct care is a nice word for free market exchange between a willing buyer and seller of healthcare services. And we can talk about direct care in other specialties as well, which I like I like how you're doing that.
Right. I agree. And any of you guys or ladies that are out there going to, come out of medical school and be an internist or something like that, you really do need to spend some time with these direct primary care doctors. They got a great quality of life once they build their practice. They can take care of people. I mean, I can tell you, Dr. Gross, for the hospital, we had a person that was on Percocet that worked at the hospital taking Percocet for 15 years. I didn't think you're supposed to even talk with a group on Percocet, so that's scary. But they were able to talk with them, had a meeting with the patient, brought in their spouse, and had a come to Jesus meeting, and were able to get that person off of that opioid. I can tell you another time where Dr. Gross talked someone off of suicide at one time that was this close at 4 o'clock on a Friday. And I can't say enough, the ability to spend time with people and take care of them. I mean, that's why they went into medicine. My dad went into medicine to take care of patients. He didn't go into medicine to call the pre-certs and all the channels they had to go through. I mean, he would come home. My dad's like me. He's he's pretty laid back. He's maybe not as passionate, but he's fiery on stuff like this. And I'll tell you I got to say this, Rebecca. I'm sorry. When electronic medical records came out, y'all know what my dad said? Do you know why he said they were created?
I can't wait.
I don't know if Pop's listening. Hey, Pop, how you doing, buddy? I don't know if he's out there. I love you, Dad, but he said so the lawyers could sue him. Here's the thing. If and y'all know this, how can you take care of somebody when none of us can multitask? Oh, I'm multitasking. If you're multitasking, you ain't listening. All you guys out there watching this webinar who are sitting on there doing email, you're not hearing what we're saying. So quit typing. It doesn't work. And my dad would say certain specialties, it could make sense. But when I went and saw my internist at one of these big hospital systems, they're typing away. He can't hear. I'm sorry. I think that's what, and by the way, when my wife had her laparoscopic appendectomy, many of y'all know about, $29,984 that we had done back in August the 6th, 2016. God, 5 years ago. Geez. When she did that, we're in there and they go, we're in the emergency room and I'm going, hey, I'm pretty sure it's a gallbladder. We're pretty sure, well, her lipase is not at this level, We need to do a CT scan. I'm like, well, hey, let me take her. I'm gonna go down the street to the other MRI place. I don't want to pay $50,000 for a CT scan. But anyway, long story short, reason I'm bringing this up, I said she had the HIDA scan done, nuclear test. And the ER doc goes, well, do you have the results with you? I said, sure, I carry them in my back pocket everywhere. So I logged on to the medical records of the other hospital this hospital didn't use the same medical records where we were. So you couldn't get it. So what good is that doing me? Anyway, I'm sorry.
No, the stories are, I mean, sometimes that's what's missing are the stories that allow people to understand how all of the insurance and how we're doing things for the most part across the country are impacting patients, that are impacting people. You know, we talk about the doctor-patient relationship, and that's what BRI is based in. That's what our whole group of Free to Care and all the Free to Care organizations are based in. We all come from it in a different way. You know, we deal with medical students. What somebody asked, what about preventative and upstream solutions?
Say that one more. It makes preventative and what solutions?
Upstream solutions.
I'm not sure what they mean. You mean if somebody has to go for further care through a specialist or go through a different channel?
That's what I'm guessing.
Well, we got a bunch of bricks in that house. We'll take care of it on our plan. I can't speak for other folks, but we would have it taken care of on ours. I mean, Rebecca, let me go back to one thing. I want to, because I know these doctors that they may not be familiar with. So this pre-cert, well, any of them that are practicing know what pre-cert is. I won't, I'm not going to say the one, but one of our clients, a large one, and I guess it's a school. We had a $3.2 million heart transplant in March of 2020. That was the first we heard of it. We get these emails from this person that goes, here's your large claimant notification for today with an exclamation mark. And I'm going, I'm a pretty fiery guy, but what makes you think I'm excited about getting this? Anyway, that was the first we heard of it. We heard nothing about it. A heart transplant. Are you kidding me? That was the first time we heard about it. And after the discount the insurance company negotiated, it was only $2.2 million. The problem was their stop loss insurance of what they were on the hook for, Rebecca, was $900,000. It cost the taxpayers $900,000 for that. Here's what would happen in our model. And this is really, really important. When that call comes in, here's what happens. Our medical management company would call us, call the TPA, call our network development partner, our cost and quality partner, our third-party administrator. Everybody would get their hands on deck, roll their sleeves up. We would have gotten that heart transplant done for $184,000 is what would have happened. And there is no medical management. Remember, I don't care. I'm going to probably, they are not in health care. They're in the money-making business. And if you want more stories, I'm glad. I'll go all day. I'll talk to anybody on a Saturday morning. I will do hours and I will talk to you, but that will not work. You guys have got to get out and get in there with the employers and get rid of these middle people.
I could not agree more with that statement. I mean, we talk a lot about, I was just reading another question, sorry. We talk a lot about how removing big government and big pharma and now, big insurance, because they're not doctors. They didn't do their billion hours of, and one of our speakers before gave the exact number, and I don't remember it, of medical school training to get to where they are, and they shouldn't be in that room. And I love that that's what you're doing, is you're working on that. You're working towards that, which I think we need to be working towards more. Somebody asked, have you given this presentation to state and local governments, even on the federal side, because people need to hear this.
Yeah, guys, the people that need the most help are these municipalities, but it's so difficult. The school districts, my God, it's our future of our country. And you would think with where we're trending with the school district with massive, our first year we saved $6 million alongside of BUCA, which is unbelievable. But we're going to be a lot higher than that. And when you multiply that money out from a kindergartner through 12th grade, $324 million potentially that will be saved that's being extracted from that community right now. And it's all about building a employer-built plan and then getting the right doctors in there. And that's what we really focus on. I mean, guys, you are the key cog that makes this go around. I know that. I said it when I was in front of those orthopedic surgeons. I don't care what hospital I'm at. Cut me open this table. I want you to do that. That's the most important thing. Don't let you forget it. To be in a patient-centric care program, the way the world used to work, you've got to do what we talked about. Otherwise, the patient's not in the center. The insurance company is. Or, sorry.
Yeah, no, I think there's no reason. I think we all have some great nuggets. I'm looking at a lot of questions. I'm going to share, just to let everybody know, in the follow-up email to this, I will share Carl's book recommendations. We had another from a doctor who's joining us. Thank you very much for that. And I will.
We'll keep going and asking questions. I'm fine. If people want to stay, I'm good. Seriously.
I have some of the students that are dropping.
Okay.
So I want to be wary of everyone's time. I will share Carl's information in that follow-up email, his contact information. I definitely highly recommend that you get in contact with him if you have questions. Also, check out their YouTube channel. The videos are fantastic. There's a lot of them. The videos are fantastic. I'm going to link the first video on the hospital that he shared in the follow-up email. Send it out, show people. It's powerful information. I think it really gets to the point of one of the points that we are, and I've said this a few times, we are trying to make about, just too much big involved in our lives and what that means. And for our students here and for our current physicians, that all of that means you are not spending the time nor using what you have done your entire professions with your patients. And it's because of too many other people in the room with you. So I think what you're doing is critical to how healthcare is going to be transformed. I hope everybody will start thinking about things a little bit differently now that they have it. I know I have. And there have been some questions about school districts. I know that was a question here. I think she'll be getting in touch with you about that.
Let's go. Giddy up.
And, I listened to something you said about the size of companies that you work with. And I listened to an interview that you did, and you're saying, 500 and larger. Is that right? Or?
No, absolutely not. I mean, look, we would rather... it's funny, Rebecca, people are like, I'm only working with companies 1,000 plus employees. No, I want to work with people that want to work with us. And with Mitigate Partners, we've got so many of us around the country. We've got plenty of resources and plenty of people. And I mean, no, 100, 200, whatever, I should cut it, but probably somewhere in that. The group has to have the ability to self-fund. And, they still have stop loss insurance. I'm not getting into the details of that, but they have to be able to self-fund. You can't do employer billed health care. If you're like where I was today I told you I was at that office today, they have 25 employees. We have to have a BUCA plan that's a level funded plan, a hybrid. It's the best we can do because they can't afford the risk at their size. So 100 plus is good. And honestly, the private employer is a lot easier. I mean, these public entities are just tough. I mean, they're just hard and they're screaming for our help and they're wasting our money. It just drives me crazy. I mean, if you hadn't noticed, it just drives me batty. And it's difficult. So, hey, also, Rebecca, if they call, guys, be patient with me. I'll do my best to respond, but be patient with me. And if you don't hear from me, ping me again. I want to help, but just be patient with me.
Carlo also has coached like 49 of his kids' teams or something like that. So, there's a lot going on here.
Hey,
I like that. No, that's great.
No.
That
was a lot, Rebecca. My daughter's a senior in nursing school down in Augusta, Georgia. We call Augusta. Master's is coming up. She's fixing to graduate in May. My son's a sophomore at Ole Miss, and my other daughter's a junior in high school. So she don't want to see me anyway.
Of course not.
So we don't just no more coaching. So I have the time, but anyway, no, I don't. No, there's just a lot. We're doing a lot of different things, but I want to help. I want to be available. I want to fix this thing, because if we don't, and then we're all going to have crappy health care, excuse my language. And the other thing is, I mean, it's such an honor, and I didn't do it. I was having trouble at first with the camera with that, getting that set up, but it's an honor to be here. It's an honor to talk to these physicians. I want to thank you for your service and your efforts. And I mean, medical school has got to be one of the toughest things and to do, period. And that you're going out and giving care to people. I grew up with my father, and I can tell you this. I mean, it was him and Dr. King, and he's on call every other night. He missed Christmas. He missed a lot of stuff, and it's tough. And I have a deep appreciation for what you guys do. And as they grew and they had partners, you know, things improved like that. But he's a great dad, but it is a lonely ride initially, especially when you're starting out. So I want to thank y'all, and it's an honor. What a great organization Benjamin Rush Institute is in trying to protect the patient-doctor relationship, which is pretty much kind of gone.
Well, that's what we're doing it from different avenues, you know, whether it's in non-for-profit world or it's the profit world. We're all doing it from different avenues, but I think we're fighting the good fight. So I want to thank you so much for your time. I'm going to put together, for people watching, I'm going to put together all of those resources, and I'll put them in our follow-up email, including Carl's contact information. So definitely get in touch with him. Follow him on LinkedIn. I definitely recommend that, because he puts out some great information that you should have. I'm getting stuff all the time, and I'm learning so much from him. Also, I want to, so make sure that you check your email for that. You can contact me at Rebecca@BenjaminRushInstitute.org if you don't get anything. I promise to follow up. I am excited. Follow us on our website and get our newsletter, because you get information about what our next webinars will be. Next month, we have friends from the Mercatus Center, which I'm very excited about. I love speaking to the Mercatus Center. They're just big brain people who work on really important policy work. So I'm excited about that, and a lot more coming. So Carl, thank you very much. Yeah. Thank you everybody for joining. Yes.
Thank you, Rebecca. I'm going to give you should share those other videos, you know, the hotel that's in the book, the school district, and I'll get you those, because in the title, if they'll click the URL, it says what it is. And guys, I mean, again, I want to thank Patient Rights Advocate publicly, Cynthia Fisher, Ilaria, and that whole Linda Bent, their whole team, and Marnie Jameson Carey, with what they're doing. I want to thank them, because if it wasn't for them, the awareness and the visibility wouldn't be as great. And with the work they did, they had a lot to do. We got a long way to go. The transparency and the tools is pretty hard. So we are allowing our clients to buy healthcare knowing what it costs up front. We're not playing that game 30 days later. So you don't have to either. You can get around that. So anyway, that's all, Rebecca. Thank y'all for tuning in. I hope people stayed engaged.
No, that was great. It was fantastic. Comments are saying so I really appreciate it. Thank you all. And if you're not already getting our newsletter, go to our website, BenjaminRushInstitute.org. Make sure that you get it, because you'll be notified about upcoming webinars. So thank you all very much, and have a great evening.
Thank y'all. Good to see you. Thanks, Rebecca.
I hope you enjoyed today's edition of the Benjamin Rush Institute's Virtual Events series. To learn more about our educational programs and events just like the Virtual Events series, I encourage you to visit our website. While you're there, you can subscribe to the Benjamin Rush Institute's YouTube channel and link not only to all episodes in this series, but also to all of our past meetings, events, and conferences. And please consider supporting our work on behalf of the medical students we serve by donating to our efforts. Your support is vital if we are to continue to provide important educational programs and events just like this one. We appreciate your support, and please watch for your invitation to the next edition of the Benjamin Rush Institute's Virtual Events series.